It's from survival to thriving, building lifelong care for congenital heart disease in low middle income countries. And this session going to be opened by Mrs. Bistra Zleva, Children's Heart Sling USA.
For a few seconds to introduce my co-panelists. Here we have actually three great speakers who will talk about the needs for lifelong care in childhood onset heart disease and specifically for congenital heart disease. Our first speaker is Ms. Amy Verstappen, who has an incredible amount and years of experience working as an advocate for congenital heart disease care in the United States and abroad. She is she was formerly with the Adult Congenital Heart Association of the United States, and then a co-founder of the Global Alliance for Rheumatic and Congenital Hearts, which is an alliance of patient and family organizations. Then we have Mr. Siddharth, who is a patient from India living with congenital heart disease as an adult. And so he will share his perspective about the needs of him and people like him living in India. And last, we have Dr. Srihari Nair, who is with the government of Kerala and is one of the people instrumental in implementing the program for congenital heart disease, which is a population health program for congenital heart disease in the state of Kerala, called Hridayam, and co-partner of me and of Children's Heartlink. So we've worked together for a very long time. So first, I also would like to express our sincere thanks to Dr. Kalangos and Dr. Shanseri for inviting us to speak about this. I'm sure everyone wants to go soon. It's in the end of your day and you want to go back to your conversations and dinner probably. And so we will try to keep this short, but it's a very important topic and we really appreciate the opportunity to speak. So I will first invite Ms. Verstappen to share her slides and to start her presentation. Thank you so much.
Thank you so much, Bistra, for the excellent introduction, and thank you all for inviting me here today. My topic is A Future for Every Heart Patient, Achieving Lifelong Care. As Bistra said, I'm the co-founder of the Global Alliance for Rheumatic and Congenital Hearts. I'm also a long-term survivor of complex congenital heart disease. For those who aren't familiar, Global Arch is a global alliance of 82 patient and family organizations around the world. 50% are in low and middle income countries that come together to connect, strengthen the organization, and create a united voice that identifies priorities for our community. One of our founding activities was to create a Declaration of Rights for individuals affected by childhood onset heart disease. And I'm not going to be talking about all of this today, but I'm going to be focusing of all these rights on the issue of ongoing lifelong care. And the reason I'm focusing on this is because when we brought our leaders together, we had 60 organizations represented in Washington, D.C. in 2024. We all worked together to identify global priorities for every place in the world. And this issue emerged as the highest priority or one of the highest priorities for all the attending organizations. I'm sure many of you, or maybe most of you in the audience, are familiar with the existing care guidelines. There's three major ones, the updated ACC, an American Heart Association, there's European care guidelines, and there's also Australian guidance. But I want to really hope or encourage you that you've looked at the updated guidelines, because recently a number of them have been updated, and the guidance has changed. And part of that is because of the emerging information we're getting about, frankly, simpler defects. So originally, there was a lot of focus on the moderate and complex defects, and that makes sense. But some of the research that's been coming out about even very simple disease like repaired ASD, we're seeing really surprising rates of mortality in the long run. And some of it is concentrated in women, which highlights the other issue here, which is pregnancy as a risk, which we didn't expect how much of a risk it would be. They're all of the defects, all of them. It's recommended that everybody be seen from between every 6 months to every 3 years. The only exception is that the European guidelines say that a perfectly repaired PDA does not need ongoing follow-up, but the US and Australia say yes, it does. I also want to really highlight the cognitive and mental health issues in our community because this has emerged as the major actual morbidity in both children and adults. I know that a lot of you right now are more focused on children. So I'm sure you know that about a third of children with congenital heart disease will have learning and behavioral issues. And the key fact about this is early diagnosis and rehabilitation is essential, that this will really improve these children's ability to thrive. So this is a major lifelong issue in terms of ongoing care. And a third of adults with congenital heart disease have anxiety and depression. Again, it's the highest morbidity in our community. And sometimes this is perceived just as a quality of life issue, but you can very clearly document that more depressed people actually die sooner of their disease. For example, if you have heart failure and you have untreated depression, you have significantly higher rates of mortality. And we know that this is a huge gap right now. So if you talk to patients and families, they will say, this is as important to us as the medical issues, and yet it is very under-resourced and under-researched. We also continue to have huge knowledge gaps. So I've been actually working in this field since 1998, and that's when really the data was emerging about this key importance of the lifelong information for everybody, patients, families, and clinicians. But we still can document and report that a lot of families really do believe surgery to be curative. That's what they continue to believe. And I also want to highlight that this perception that we tend to think that loss to care happens in the teen years. And I think part of that is because we tend to do studies like we start at age 12 and we look at then see how they do. But the truth is, particularly if you look at registry-based data, public health data, the majority of children actually, even in high-income countries, drop from care before age 13. So they're already gone. And it makes sense in some ways because a lot of kids do really well. And so they don't come back because they're doing really well. And there's also a big gap in patients and families' ability to recognize and report symptoms. So if you tell me I need to keep getting care, unless you tell me, okay, you may be at risk, probably not, but for heart failure, and if you start swelling, here's who you need to call, I can't effectively take care of my long-term issues. So in a nutshell, most children and adults in globally, every place, high and low and middle income countries are not getting that needed regular high quality care. Um, Obviously, in low and middle income countries, there's different barriers, including the shortage of pediatric care. The major issue in high income countries, beyond the knowledge gap and the funding gap, is also we just have an acute shortage of adult trained care and services. This is an issue I've been working on, as I say, my whole career since 1998 has been focused on this. And it's just blaringly clear that we need new approaches. We need new approaches that actually work better for patients and families because we're failing right now. In response to this issue, Global Arch has worked and is working on creating a lifelong care principles framework. So what this is, it's a collective statement from patients and families, and we've solicited and continue to solicit input from all those 82 organizations to get them to make sure it reflects everybody's needs. And the idea of it is it's a global standard of what every patient should get. It is not clinical at all. You will see that. It's focused on service, provision, and information that we see as knowledge gaps and service gaps. I want to stress this is not just about adults. Sometimes I think people think lifelong adults. Actually, this is all the care post initial diagnosis and intervention, right? So if you have a child, they have a surgery. So what happens next for that child? Not just when they're 18, but when they're 6 months. We wrote them to address RHD and CHD, so every principle is actually meaningful for both populations. As I say, it's children and adults, and all of them are based on guidelines and research. You'll see a lot of little references at the bottom of my slides it's not easy to see, but just so you know, this is not just opinion. It's also based on what the guidelines and the research recommends. And finally, I really want to emphasize that this is aspirational. Like the Declaration of Rights, there is no place anywhere on earth right now that achieves this, and probably it will never be perfect, but this sets a standard that each of us have a right to expect and we want to achieve. So these are the principles. The first three are focused on knowledge. Every patient and family should understand that what they have is lifelong and they need to keep getting ongoing follow-up. Every patient, including that baby that just had surgery, they need to have an identified cardiac care provider and they need a long-term care plan. They need to be told you need to come up back every X years. I'll see, know that information and it needs to be realistic. And as I mentioned, we need to know not just come back, but here's the things that might happen. Doesn't have to be scary, probably won't happen, but if these things happen, this is what you need to do. Actionable. I went. These are the most obvious things. Every person needs access to full medical care, to all the medical staff, and also the medical services and medication. But what I want to highlight here is those words, treating their disease in their age range. Okay, so I'm 64, and I need to see somebody who understands the aging congenital heart, not just somebody who works in babies. And, that's the quality standard, because when older people don't see pediatric cardiologists, they're not trained, they don't have the experience, and they need that special training because we get different things than kids do. And on the other hand, adult cardiologists around the world, I know in the US, have minimal training in congenital heart disease. So in the US, if you train as a sort of regular adult cardiologist, you get 6 hours of training and there's no requirement to see a patient. So very poor quality care and worse outcomes if you don't see somebody who knows what you have and how to treat it. Cognitive and mental health. I can't stress this enough. All of us should be getting the services to prevent, identify, and treat both cognitive and mental health challenges. Those children need to be getting identification and rehab, and the adults need to be getting services. Pregnancy and reproduction. Women need to not only get the services they need to minimize their risk, but they also need to understand safe family planning options and understand that for most of us, we need to plan our pregnancies because we need our heart checked ideally before we become pregnant. There's a lot of things that are easy to address before we're pregnant that are much harder to address when we are pregnant. This is one that's often neglected, that patients and families need to be educated on the benefits and safety of physical activity. Many, many patients and families around the world report that there is still a continuing perception that this isn't safe. And they really need to know about this because that is a key way that all of us can make sure our funky hearts last as long as they can, is if people are physically active. And finally, community and belonging. So it can be very isolating to live with congenital heart disease, and both for the families and the patients. And what we can see from our 82 member groups around the world is being able to meet somebody who has your disease, share those challenges, share the challenges of parents, is truly transformational. It helps your knowledge, it helps you manage your disease, and it helps you understand you're not alone. So those are the principles, very simple, trying to be very clear. I hope you will see these again after they've been more formally published, because we're asking for endorsement. We will be coming to you if you run an organization and saying, will you endorse these principles? And we're not asking, do you do this? But do you agree that this is needed? And as I said in the beginning, the reason we're doing this is there's a big gap right now. Everybody you meet actually will now say, oh, of course people need ongoing care. But if you look, just even count up the sessions at a conference or count up how much of people's training are spent on this, there's a big gap with the patients and families saying, this is urgent. We have to live our lives, not just get those surgeries. And what tends to be the focus of clinicians, because you're not living with the issues, so this doesn't come up. What you see is those acute things when we come in for care. And finally, for us, we will be using this to educate patients and families at Global Arch. That's sort of our job, is to help those groups to do that. But there needs to be a lot of problem solving. So partnered work where patients and families and clinicians, humanitarian groups, NGOs think about how can we address some part of this. So, for example, if you are involved with or run a humanitarian group that provides surgery, do you fund people? Do you fund those follow-up surgeries? Do you follow people? And also just over 18, many of those foundations don't fund surgery for even their own people that they operated on. So these are really concrete things you can do. How do you talk to people? Because we recognize that in low resource settings, this is hard, but at least you can make a plan of how you're going to do this better. That's the principles. I know at the end of the day that every person in this room does not want to get children just to age 18. We want everybody to thrive. So we hope that this initiative will help that, and we hope that this conversation will help us here think about problem solving. Thank you.
Beautiful. Wonderful, Amy. Thank you for sharing this work. I just want to say my organization, Children's HeartLink, very much supports this work and is partnering with Global Arch to think about how we're going to have more discussions to disseminate these principles. And we are definitely going to endorse them. So next, I would like to invite Mr. Sidhant Rathi, who is a patient living with congenital heart disease, and one of those people who we recently actually got to meet. I was at the Pediatric Cardiac Society of India meeting in September, and Sidhant and I were on a panel organized by one of the patient organizations, newly formed patient organizations in your country. And so he will share a little bit about his experience and how lifelong care applies to what he's living with. So Sirhan, maybe you can share your slides.
Yeah,
Great, we can see them. Thank you.
it's great. Well, thank you for the wonderful introduction. And today I'm here to talk to you about living with a CHD. So I will begin first by giving a short introduction about me. I work as a software or AI engineer, and outside of work, I like volunteering, meeting new people, and in general, doing things that make me learn more about the world around me, with the intent that I find things that wonder me or maybe learn things that make my life better. So this is one of the images I took a few days ago. This is a rose petal under a microscope, and I was actually amazed by the richness of colors it had. Uh, so I have a complex congenital heart disease which was untreatable at birth, and eventually it developed into Eisenmenger syndrome. So I lie outside of the conventional CHD conversations that focus on surgery, because for me, there is no overshadowing big event of a surgery, and then the medical care kind of takes a hit. For me, it has rather been a continuous journey of kind of facing new types of problems and then adapting to them and trying to learn to live with them. So today I'm going to use my time to share a few open-ended anecdotes with you. Uh, Firstly, I will share something about the psychosocial challenges, and I think many of the people might have heard this, that there are things like body image issues, low self-esteem, fears due to what might happen to you because of your health, and then of course fears of being a burden on your family or on your loved ones or on your support system. And I had all of these problems growing up. But what I want to tell you today is that for me, there was a major theme throughout time. So there were career and loneliness. My anxieties were mainly uh, focused on these. So whenever I was doing good in career, then the loneliness would take over, and if I was doing good in terms of my friend group and all, then career anxieties would take over. So In 2020, when we were in a lockdown, uh, this loneliness actually became very intense for me. And just to give you a background, that I have been very socially active since childhood, and I have a very good friend circle, a very good and supporting family. And even after all of this, I have always felt that something in my life is missing. That there is a lack of a sense of belonging. Now, coming to 2020, I was feeling very alone, and here I am on the internet searching for, are there any other people with CHD I can meet who have maybe similar problems who I can talk to about it. So, link by link, I came across an American Adult CHD group, and I think it was the first time in my life that I was in such a group where there were people suffering from not exactly the same but similar conditions as me, had similar problems as me, and maybe also similar energy levels as me. And it really helped me at the time. But I would say ki still this kind of feeling of being an outsider, not belonging, still was there because those people coming from a very different cultural context, and on top of it, I didn't really have an opportunity to meet them physically face to face. So I'm 25 now, and till 23 years of age, I never met an CHD adult in real life. So it was when I was 23, I first met one. However, fortunately, last year I joined some pulmonary hypertension and CSD communities, and I also got to attend their meetups. And what I feel is that it kind of completed one part of my life where there was something lacking. I felt complete, like a missing piece was there. And I would acknowledge that this does not solve all of my struggles, but it led to that feeling of isolation or of not belonging go away, because now I was surrounded by people who came from maybe more or less similar cultural background, more or less the similar maybe financial backgrounds, who had the same problems as me, who were living nearby me. And I think this would help me going forward to build a solid foundation for my mental health. At least it is a good place to start. Now, again, I will tell you a bit about my medical challenges. So, when I was born, it was a very complex CHD. We went to different CHD centers around the country. All of these CHD centers in their prescriptions wrote that, oh, please follow up after, let's say, 3 months or let's say 6 months. But from what I know by talking to my parents, it was never emphasized enough, or sometimes it was just mentioned in the prescription, but not mentioned during consultation. So for 14 years of age, I never really had regular follow-ups, which is kind of a recommendation for folks like me. And I would like to add that this is not just a problem for me, but I have seen many of my friends and many of the people with CHD I know not really going to regular follow-ups, either because there are very long distances to travel to go to a very good center, or maybe they don't have enough resources to pay for doctor consultations or the tests which are required at every follow-up. And sometimes they also have this kind of a perception that if you are going again and again after 3 months or 6 months, and nothing is coming out of it, your doctor is saying you are well, so they think that, oh, is it like the doctor is again and again calling me just to take my money or something? And what I want to say is ki maybe we need to find a way to emphasize this and communicate it to patients in an efficient manner, so that they know why follow-ups are necessary, why they are needed, and how to use them, like what kind of questions you can ask, or what kind of things you will find out. And again, as with follow-ups, I didn't even have regular exercise routine for years. I actually started exercising this year only because so far it had been contraindicated for me by many of the doctors I met, because I think the earlier guidance was key. People were a bit conservative about exercises. And what I have found by light exercises is that my posture is now better, and I think because of it, or it being a factor, I'm also able to breathe a bit more clearly, which actually helps me because I also have pulmonary hypertension. Again, on a large kind of, if I give you an overview, when dealing with my own medical problems or my own medical decisions, there are always feelings of confusion, unpreparedness, and sometimes even a feeling that, oh, I'm not even competent enough. Because when I see other people who are maybe same age, older than me, more experienced than me, even PhDs, they are very precise with their decisions. They know what data is out there, what data applies to them. For me, I kind of uh, try to go through the papers, but unable to find some case which is similar to me. Don't know what applies to me, what not. And I think to a certain extent, now I'm already trying this with my doctor, but yeah, to a certain extent, this can be solved by discussing the data which is available with your doctor, like if they can provide it, and also maybe taking some time to prepare questions and discussing them in depth. And I realized that, especially in India, there's a systemic issue that there's a huge population and very less number of doctors. So it's very difficult to give a lot of time to explain things in depth to a single patient. But I think slowly over the follow-ups, asking these questions and getting clarity is the approach I would take going forward. And I would also say key for maybe for newer patients, what we can try is kind of nudging them in the direction of data, or maybe exposing them to a bit of data and how these decisions are taken, because a lot of patients are really kind of have these same feelings of confusion and unpreparedness and all, and are going everywhere to get clarity. And yes, finally, again, this is again a systemic issue that we have a lack of insurance and policy support, which leaves people on their own to deal with health specific problems in all different facets of life. So, a very recent thing with me. So, I graduated like 2 years ago, and though I have been in very renowned organizations, I would say that in most of them I have faced some or the other kind of discrimination because of my health condition. Now, I just shared with you very few open-ended anecdotes. Like you can make what you want to make of it, or how you think we can make the system better. This is where I will share my perspective on what I think we can do to make things better. So, I think what we can aspire is to have a medical care system that is based on care that is continuous, informed, holistic, and quality of life centric, rather than just based on a single cure. And I would like to emphasize this quality of life part, because what I see now is there is usually a surgeon who operates on a child, and then there is maybe a doctor with who they follow up, or maybe one or two doctors with who they follow up, and then maybe they follow up, and after like three, four follow ups, they disappear. I think what we would really need is a rather than a single or two people, maybe a team where we also have people who teach exercise, people who give you diet advice, people who look after not only your heart but also maybe lung doctors and all. And this entire team can function together to not cure the patient, but to ensure that the patient is able to achieve their goals and have a quality of life that they aspire to have. And finally, doing all these things is a very big systemic and policy challenge. So I know it is hard, but if anyone is kind of trying to think how we can do it or trying to figure out how to do this, I'm really happy to help. I can lend you my skills. You can contact me. And I would like to just end this by saying that let's aspire to not just focus on extending people's survival when we treat them, but also maybe enabling full, meaningful, and connected lives and experiences for them, so that we have like a quality of life based care rather than just a cure based care going forward. And with this, I would thank you and take your leave. And sure, you can contact me at my email address if you have any questions or any suggestions.
Thank you so much, Sidhant. Wonderful presentation, beautiful in both in terms of you sharing your perspective of how you're living with this condition, but also kind of making us very specific recommendations to clinicians of what can be done. So really appreciate that. I just want to again highlight that there is an organization. It's called the CHD Alliance of India. And they are patient-led, patient and family-led, and they're really trying to partner with clinicians in the country and partner with the Pediatric Cardiac Society of India to actually advocate for policy changes, what you were asking on your last slide. So the last presenter that we have here is Dr. Srihari Nair from Kerala and the Kerala Government of Health, Department of Health. He will share a little bit about, from his experience of developing a patient care continuum, what they have encountered actually from an actually policy perspective or someone who's implementing policy from the government, what the challenges that they've experienced and maybe some recommendations and experiences that they have. Srihari, go ahead to share your slides.
After two wonderful presentations, one from my patient advocate and one from a real experience of a patient, I'll be talking a little bit about what government did and why government had to think about that. So this is some experience we started by doing things in 2016 when we started thinking about the Sustainable Development Goal. I would like to start from where Siddhant stopped. But unfortunately, we started thinking about all this based on the survival perspective. So this is a population-based approach for screening, referral management, and follow-up of children with congenital disease. So as you know, India has progressed a lot with regard to the survival part. In the last 2 decades or plus, maybe 2.5 decades, India has marked significant improvement in infant mortality rate. But for Kerala, from 2000 to 2015, the IMR was stagnant. That's the reason why we started thinking about congenital heart disease, because we found that the reason for mortality at that point was mostly contributed by congenital heart disease. So actually, we thought of survival, improving survival. That is the reason we started the program. So first thing that we did was a resource mapping of what is available in Kerala with regard to the human resource infrastructure, the load of newborn cardiac cases and the surgeries, what are the protocols and the logistic support, etc., which are available at that point in time. Presented all this to the decision-making body and the stakeholders concerned, and recommended to have a special program for children with congenital heart disease. And based on that, we developed a patient care continuum, which is the first thing that we did with the help of Children's Heart Link USA. Bistra was one of the key person involved in it. So we defined the care pathway with the barriers and the opportunities at that point within the health system of Kerala, starting from case recognition, diagnosis and prioritization. That is a very challenging thing. Usually the cases get detected when the babies were very sick, desaturated, getting admitted to the newborn ICUs, and most of the time they will be stuck in the units without a proper diagnosis. And sometimes even the not that sick children will be referred to higher centers, the surgical centers, but they may not necessarily to be sent to these centers. So then the referral was a challenge. We didn't have enough transportation facility at that point, even for the otherwise sick newborn. That is something that we identified. Usually, the patient once identified children with congenital heart disease, usually or suspected to have a congenital heart disease, will be transported without stabilization. That had created a lot of problem for us. Most of the time, the babies were dying in the transit. And for treatment, the major challenge was finance. Even though at that point we had two government institutions operating and almost 5 private sector hospitals operating. The government hospitals, even though it is free, the number of cases were high. We had a waiting list of almost 3,000 to 5,000 patients in one of the major center, which is one of the center of excellence in the country. The other center was not unable to take care of some, especially the critical babies. So uh, we even in the private hospitals there were slots available, but unfortunately the people were unable to pay for it, and there was no follow-up program. Uh, organized follow-up program there. So all these things were uh, recognized, and we developed a care continuum. We focused mostly on the survival part. So we looked at these specific conditions which are contributing to the major mortality in the 1 month to 1 year group. The specific conditions: duct dependent system and pulmonary circulation, transpositions, TABBs, and single ventricle variants. So the key objective was the reduction of IMR, as I said, that is ensuring survival of all possible cases. A strategy was developed which is to operate on all newborn and infant with critical congenital heart disease. The challenge, as I said, was early identification was one of the challenge. So we went for the screening program for every newborn, which is CVS, the cardiovascular system focused physical examination combined with pulse oximetry. Fetal heart screening, even during the antenatal period, screening and identifying was one of the things that we attempted. Later in 2021, we changed the strategy to operate on all congenital heart disease, not only the critical diseases. So at that point, the scheme available was Rashtriya Bal Swasthya Karikram, RBSK, one of the most important and most successful program in the country, which actually looked at improving quality of life rather than survival. But the survival was also a problem at that time. So that scheme was supporting buying services which are not available with the government. But there was no policy and formal agreement for partnership with private organizations. That is something the government has decided to go for. The state government of Kerala decided to go for a private-public partnership to ensure that all the surgical slots in the state are available for children registered in the program. So a schema was defined. Pulse oximetry screening, the screening program in 24 to 48 hours of life of every newborn. The screen positive cases will be seen by a pediatrician or a neonatologist. The case will be referred for echo if found necessary. All echo confirmed cases will be registered in a single web registry, which is we call as Hridyam. So all the critical congenital heart disease will be given priority based on a categorization, arbitrary categorization we developed, and the definite date for surgery will be provided as per the criticality of the condition. Then until the surgery, the cases will be followed up either in the community or maybe in the hospitals. Then all the non-critical congenital heart diseases like ASD, VSD, PDA, those cases will be sent back to their home after stabilization. They will be followed up in the community by the community nurses during the immunization sessions that usually happen in 6, 10, 14 weeks in the state, then followed by a regular protocol which is developed with the support of experts, and the nurses, the community nurses were trained. We had community nurses for doing all these activities for every 20 to 30,000 population for a Gram Panchayat. So they were trained on that modules, especially on the pre-surgical follow-up and the post-surgical follow-up part. So after the surgery also they will be followed up. So there is a pre-surgical and post-surgical follow-up program developed. As I said, there are training modules which are used to train these people. Even the post-surgery, there was a schedule for seeing the patient at 72 hours after the discharge from the hospital. They will be looking for specific things, and then the 7th day and 14th day they will be called. The telephonic call will be given. 1 month they will be called back to the hospital for the follow-up. Then 3 months and 6 months and so on until they are 18. That is what that we developed. A specific program for neurodevelopment follow-up was started in 2022 based on again the evidences and um, the information that we got from the registry. and some of the papers published by our clinicians. So mostly the follow-up were happening in their households, mostly with the home visits. Immediate, as I said, the immediate post-operative for wound care. We developed particular uh, training material for even for the families, pre-surgically and post-surgically, how to manage, how to take care of the child before surgery and after surgery with regard to their vaccination schedule. So what all things they need to do, uh, on the activities, feeding advices, and medication, all those things were leaflets and the training materials were developed with the support of Children Heartling. That is being disseminated to all the nurses who are counseling the family, the parents. All this contributed to improved registration, decreasing the mortality, all those things. This is the neurodevelopmental follow-up protocol that we developed. All those children were screened using the scale Darcy, which is one of the neurodevelopmental scale that we use in India. So again, the district early intervention centers at every district were asked to see there is a multidisciplinary team, especially the therapist and a pediatrician. Under the leadership of the pediatrician, they'll be seen, they'll be looked for other anomalies, other maybe including the neurodevelopmental deficits. Then they will be treated, maybe therapies were given, and there will be a follow-up at regular intervals until the modifications are made. So we found that the all follow-up program improved the cost efficiency of the system, especially by using the multitasking of the health workers that already in part of the system. The existing human resource were trained using separate modules for that, especially the capacity building happened through modules developed for particularly this activity. Existing infrastructure like BAIC and the primary care facilities were used. The equipments already provided for the RBSK nurses, the RBSK kit were the one that we use for the follow-up program. This is what the data that we had. This is a continuous registry started in 2017. Till by this time, we have almost 20 to 23,000 children registered with congenital heart disease. And we focus on the data analysis and the information that we gather from the data set. Based on that, the policies and the activities are being reframed at regular intervals with the help of experts. So you can see that this is one of the study that we did, and that could really improve the survival of the critical congenital heart disease. Usually 70% of more 50 to 70% of the children otherwise will die. You can see that from our data 2018-19, the mortality was reduced to 22% for even the critical congenital heart disease, and among the severe category the mortality was only 7%, and in mild to moderate cases most of them we could survive. And this the whole was published, and in the paper itself we wrote that the infant mortality in Kerala has substantially reduced, and the program has contributed significantly to the reduction. Through our learnings, we started developing transition clinics, especially one of the empaneled hospital, the private partner, started doing an adolescent congenital heart disease clinic, focusing on the adolescent issues, not only the cardiac problems, but the behavioral issues and other sort of problems. So they were doing it for the last 3-4 years. One particular pediatric cardiologist was trained and given the responsibility for running the clinic with other supportive team from other specialties. Special management and follow-up clinic for pulmonary hypertension was also established in the same hospital. A big cohort of children who didn't get the opportunity to get operated or maybe unable to, as we saw in the last case, um, could not have a surgery possible even at the time of diagnosis. They were all being followed up, and medicines were provided, and maybe the appropriate treatment as per the latest guidelines are being provided. The adult congenital heart disease clinic, both adults who have corrected the conditions or uncorrected CSTs come. Even the people come at the age of 80 years because the AF and other conditions, they are being treated and supported there. Of course, we have challenges. There are no financial coverage after 18 years. That's one of the problem for us. The RBSK scheme covers only up to 18 years. As Siddhant told, there are no, the insurance policies or anything take care of this part. There are some discussions happening with regard to the state-funded schemes to include the medicine and other sort of support through the NCD program. NPCDCS is another national program that is giving care and services for people with NCDs. No organized system for psychosocial support for parents and children with congenital heart disease across the state because the primary care and other, even we are really working on improving the psychosocial problems of antenatal or maybe other children, but there are no organized system for children with congenital heart disease alone. They have it is trying to integrate that with the existing systems. Awareness among clinicians and patients and family, of course, on those parameters what Stephen was talking about. What to do, whether there is a need for continuous follow-up, all those things are missing, especially on the pregnancy part or pre-pregnancy counseling sort of things that we miss, that the government is seriously looking into. There are some discussions happening with one of the Center of Excellences, Sri Chitra Denal Institute, and they have started some clinics as a pilot. That's maybe in the coming years, definitely that will be part of the whole system. This is always one of the challenges that everybody looks at, whether going for such a program is cost effective, especially when we say that congenital heart disease is something very complex and very resource intensive. So we have done an HTA on the program. We found that there is an ICR of significant ICR and there is a significant QALY gained with this program. And the budget impact also, the budget impact analysis was also done, which shows that there's only around not very high increase, but a marginal increase in the total expenses for the government for having such a program. Thank you.
Thank you so much, Srihari. So we heard yet a third perspective of this issue from the government, and I know these are typically clinical meetings. I have been attending the Global Forum for many years, but I would like to invite now the other two panelists to also join on the screen, and maybe we can take some questions. I know it's at the end of the day, but I have one specific question that I hope everyone can try to answer is, this is a meeting for mostly organizations, NGOs, humanitarian organizations. We have met a lot of colleagues over the years. What can organizations like Children's HeartLink and others do to make this, a more well-known issue and to correct this problem? And Amy, maybe you can start.
Sure. I think one thing to start with is, well, let me back up and say, I think the first thing is thinking some kind of assessment, could be an easy assessment about how well are we doing with this, what are we doing well, and what can we do better. And also, I like to say that if you don't have a checklist about doing something, you're not going to do it. So I think having more specific tracking about the lifelong stuff, I know this can be, burdensome, but it could even be as simple as, here is like a vaccination card. Here is what we give families that says very clearly, not a lot of information, but just here is how often you should be coming back. We're going to stamp this off. So creating mechanisms from the very beginning that really underline that. I also think the training. I know that Children's HeartLink has quality metrics that they apply. And I think that in the future, you could think about maybe a quality metric is some kind of quality metric about training on this. Maybe a quality metric is follow-up. Like, let's just look at what % of those children are still coming to care at age 8. So those kinds of systematic approaches, and start simple. As I said, if you're a humanitarian group, do you fund, ongoing surgery, and how or do you have any mechanisms for those kids whose lives you save to come back to have that continuing care?
Yes. Srihari and Sidhan, do you want to make a comment as well on that?
Um, yeah, I have two things to tell about this. One, of course, all these sort of organizations can really attempt to bring this as an issue to the focus of the government. So government will have many priorities, uh, mostly about the very usual things, the infections, all those sort of things. But uh, you need to go back to the concerned authorities at regular frequencies, knock the door repeatedly, so that at some point definitely they will have to open it. That is one thing. Second, on the bringing the expertise and the information from different parts of the world. That is something that government will never search for. So that is something that you people can bring in and talk to the concerned stakeholders, make them aware, so that that is what happened with our program. As you know, we went around. You people came to us. Different experts from different parts came, and they started talking about it. And then we realized that yeah, we are lacking. We need to do this. We need to do the next thing. So that is something that definitely all these organizations can definitely try.
Like,
Yes.
Sidhan, uh,
Sri Hari, Dr. Hiremat from Madhusudan Institute of Medical Sciences, cardiac surgeon over here. It was an excellent presentation, especially regarding the infant mortality rate at Kerala, what we have been presenting. And I saw that stagnant of around 12 per thousand for more than 6 to 10 years. Subsequently, it has come less than 5 per thousand labors. Why this model of Kerala model of IMR has not been attempted across other states in the country, and we want some inputs how we can implement at this part of the country where ours is a totally philanthropic organization, and how we can implement your thoughts and ideas to reduce the IMR.
Thank you for the question. This is yesterday I was attending one meeting with ICMR. The same question was asked by the professor of pediatric cardiac surgery from All India Institute of Medical Science. So this is something that I wonder why this is not happening in other parts of the country. Usually, every time people tell us the states are not ready, this what the Kerala can do it. Kerala had a very less IMR, and then you can do it. But that's not the thing. We need to focus. We need to focus on improving the survival. We need to identify the cases. Mostly, when we look at other states who are doing surgeries, we saw that they are focusing on a different segment of children, like little elder children, 2 years or maybe 3 years or maybe the school going children. That is not going to reduce your IMR. If you want to reduce your IMR, you need to work on that particular group of children. As you know, you people are the experts. That will be a little difficult. The newborn surgeries or maybe the critical congenital disease identification and operating. So you need to first develop a continuum of care. You need to plan it. Okay, there should be some plan for case recognition. There should be a screening program. There should be an organized system. Indian Academy of Pediatrics Kerala chapter helped the government a lot in timely referral of cases. So we conducted series of workshops, CMAs for the pediatricians, on identifying the cases, timely referral. There is a protocol which is available and which is a very transparent system. Anybody can register in the portal from anywhere. There is no need of a particular referral. You just need to register the case in the system, so that that will be taken over by the government system. So something like that should be developed by any state. This is possible by especially any southern Indian state. We have very good connectivity, and only the one thing that we need is to recognize the hospitals or people who are doing the sort of good work that they are doing.
Yeah, thanks. I think
And
I can touch base
if I
with
can
you,
add
and
to that,
we can implement starting with our institute here, so that in Karnataka we can set a role model and take it around.
if I can just add to that, since we were
Thank you, sir.
there
Thank you.
implementing
I'm
this
very happy to
program.
help.
Yeah, with it, I think a key piece here is to understand where exactly the infant mortality is coming from, and to actually look at the data and do an initial assessment, and also to have the capacity to do infant and newborn surgery. I think that was a key success factor for Kerala, that they had enough capacity to do that. But I also want to bring back to the topic of this session, that is about lifelong care. We did not think about lifelong care from the very beginning as we were doing this project, and so that's, I think, a very important piece, to just continue to be thinking about how that gets implemented. I just want to give one last chance to Sidhan to comment on this. And Sidhan, you don't have probably experience with NGOs and humanitarian organizations, but perhaps you can share maybe what do you think patient-led action can be in this, patient and family-led action can be in this process. What can be done?
What can be done? Look, there are a lot of, I mean, I don't think I'm really the right person to tell you this because, frankly, I do not have enough data to comment. What I can tell you from now is that what I see is there are some problems which can be mitigated by small steps in the short term. So, very simple steps like you can guide, like, some patients come to you, you can share your experience, or maybe tell them how to approach a follow up, or these simple guidance and information dissemination. But there are also long term systemic challenges for which I think a lot of people we need to come together and firstly kind of decide what we want to achieve and how are we going to measure our progress towards what we are achieving. And I think you guys are already doing this with the principles which Amy highlighted. I would actually go through all the data in detail, and I think then I would be in a better position to comment on the long term things.
Yeah, the CHD Alliance of India is definitely it's patient and family led, engaging clinicians, and so it's trying to advocate for policy changes. I see Dr. Seti is there.
Yeah, I just wanted to, I did have one question, but I wanted to thank all the speakers. This was a wonderful session. Bistra, your work with Children's HeartLink and your colleagues has been amazing over the years. So we wanted to thank you for that. And Miss Verstappen with Arch, I think, I think there's a lot of work to be done, and I think you brought that out really well. Siddhant, your talk really hit a lot of us. It's always nice to hear from the patients themselves. So thank you for doing that, Dr. Nair. Your work in Kerala has been amazing. But the one question I had that, and this isn't necessarily even a humanitarian question. It's a congenital heart disease question. I can speak for the United States. We have a really poor system transitioning our patients, right? Pediatric cardiologists to adult congenital heart specialists. We actually have a board for adult congenital cardiac or cardiology. And it's amazing to me to see how many patients we get referred to us for surgery that didn't know that they needed follow up. And they're in pretty bad shape when they come see us. And so, I think this is a worldwide problem. And so, any of you can answer this question, but like, what is the one thing we can do? Like, I would think it would be a, a responsibility of a pediatric cardiologist to transition their patients to the right specialist. So, any ideas on that topic?
I'm going to go ahead and start. One of the mistakes, I don't know, is there any way to get me bigger? It doesn't really matter, but one of the mistakes, having worked very hard in the US, on creating the US system that we have and getting that certification. But I think the mistake we made in the US, frankly, is because we started from the adult end. And I think that another mistake we've made, and I referred to this, is initially, and you can look at all the papers, I was one of the people working on this, we had a big focus on transition. And I think actually, if we want to really address this problem, we have to really cooperate with the pediatric space, both the pediatric patient family organizations and the pediatric organizations, because basically, and I think Sidhan was really great at this, we tend to focus on the patients who have recurring health issues, and that's what's coming back. But how we have to keep people in the system is better education, for one thing, about this is what you're at risk for, because in general, there's lots of research on this. Clinicians tend not to bring that up, but unless you can give somebody a concrete reason, and as you said, you don't want to wait too long. So to say to a family, to, for example, that person who's had the complete repair for transposition, look, we don't think this is going to happen, but we have to look every year, because if that happens to you, if you start whatever in your heart, there's changes, we need to deal with it sooner rather than later. And it's a challenge because you have to keep people in care for a really long time. It's the continual thing. As I said, if you start with the people at 12 or early adolescence, you've lost more than half the people already. And I know, I just always say data, 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 look at the registry data. So I think more collaboration across that pediatric adult congenital divide, I think more collaboration with the patient family organizations. You have great ones in the US. And I think, frankly, the other issue is more thinking about better solutions, because I think COVID taught us that you can do a tremendous amount with remote. You can do a tremendous amount seeing people remotely. So basically, people don't, it's very burdensome, even in countries unlike the US, where your care is treated, to travel and to go to specialized care. And so we have all kinds of potential technology and remote solutions to do better partnering with the community cardiologists, which, I have AFib and heart failure, and that can be effectively treated in the community as long as there's that input and sign off from the people who know about what I have. So those are a few a few thoughts on what I think. And again, the countries that are developing this have a huge, huge advantage over what we had in the rich countries. You guys can plan for this and think more creatively than we did. Thank you.
My comment will be quicker. I just want to say we should learn from the public health field. We have focused on congenital heart disease as a surgical condition. And of course, that's important. Surgery is the key aspect of, repairing the conditions and giving patients, life to live. But I think the communication has been so much focus on this first part of life, which again is very important, and not enough focus on the communication of this is a chronic condition and you will need lifelong follow-up. It may be minimal, just seeing, someone on a regular basis to just listen to your heart, or it may be at 23 years old, you might need another surgery. I think that communication piece is missing. Probably because no one wants to tell a family that has gone through this traumatic experience of, having a newborn or a young child be in a hospital for a very long time. But I think that communication piece of that this is a chronic condition and in chronic condition needs follow-up care is a little bit missing. And I don't think that's a fault of anybody. Our field has been developing, even for the last 20 years that I've been working in this field, has been growing and developing. So it's time for us to make yet another step in the growth of our field.
I have a quick comment. Definitely, we need to start working with the families and the patients um, regarding improving their knowledge. They need to be their own the advocates, and for that, the best option will be targeting the pediatricians, because they are going to see these children for at least 13 years, even in India, maybe 18 years. So the pediatricians are the right advocates. They can talk. They need to be trained. They need to start talking about all these things to the families. May not be maybe at 1 year, but at maybe 10 years, 15 years, they need to talk a little bit more about the condition and what they need to do in their uh, the longer life. At maybe 25 you need a surgery, or maybe 18 when you are planning for your pregnancy. All those things can be very well discussed with the family by a pediatrician. So we need to focus on the pediatricians, train them, and definitely we need to decentralize, as Bistra pointed out. that the primary care definitely has contributed a lot in the low and middle income countries. So the primary care needs to be empowered to take this responsibility on patient communication.
Yeah, thank you so much for those answers, and I appreciate the group joining us, and we look forward to hearing more from you in the future. So thanks again.
Okay. Thank you.